Currently, there are a number of national guidelines that are available. Most notably are the NCCN guidelines and ASCO guidelines. They are very similar, but they do have slight differences. The guidelines generally break chemotherapy down into 4 categories: highly emetogenic, or what we call HEC, moderately emetogenic, or what we call MEC, low or minimal. Then we look at the time of when the emesis or nausea happening, either acute or delayed. Acute we define as having happened within the first 24 hours of chemotherapy, delayed happening 24 hours to about 120 hours after chemotherapy. The definitions for HEC, MEC, low, and minimal are based on the risk of the chemotherapy agent or combination agents themselves. When we look at chemotherapy and are trying to devise an anti-emetic regimen, we look at those agents or a combination of agents. We place them into one of those 4 categories and make determinations as to what anti-emetic we're going to use. For HEC, all the major guidelines do recommend a 3-drug preventative anti-emetic regimen. That would be a 5-HT3 in combination with an NK1 receptor antagonist, as well as dexamethasone or corticosteroid. These agents should be used each day of chemotherapy if it's a multi-day regimen, or if it's a single-day regimen, they need to be given 30 to 60 minutes prior to the chemotherapy for that day. If it's a single-day regimen, then we would also add prevention for delayed nausea and vomiting. And again, that's going to usually be a combination of a 5-HT3 and steroids. Now, with some of the newer NK1 receptor antagonists that have a much longer half-life, or agents that's formulated to have a much longer half-life, you may not need to add anything in the delayed phase. If you use a first-generation agent, 5-HT3, you will need to add additional agents in the delayed phase. For moderately emetogenic, we generally recommend a 2-drug regimen, and that would be a 5-HT3 plus a corticosteroid. Once again, in that setting, if we're talking a single-day regimen, you would add additional antiemetics to control or prevent, rather, delayed nausea and vomiting. For low-risk agents, generally just a single-day either dexamethasone steroid or a first-generation 5-HT3 or dopamine blocker is generally recommended, and no additional therapy is needed in delayed phase. And then for minimal agents, no antiemetics, preventive antiemetics are required. You would only give antiemetics if there was a breakthrough. Breakthrough nausea and vomiting, generally again is defined, is happening after adequate preventative antiemetics prior to chemotherapy. This is also an area of unmet need, an area that needs further research. There's been multiple agents that are being studied from first-generation 5-HT3s, which have shown to be not very effective in setting. They're much more effective in the prevention and acute phase, to some of the atypical antipsychotics like olanzapine, steroids, and combinations of steroids and dopamine blockers. Currently, right now, there's not great recommendations from the national guidelines as to what to do in this setting. Generally, it's recommended you're going to try a class of agents that was not used in the preventative phase of therapy.